Hello, everyone. So I'm Alexandre BELOT. I'm a pediatric rheumatologist in Lyon. And within the FAI²R webinars, I've been invited to speak about the update about monogenic lupus with a specific focus on type 1 interferonopathies. So in the following slide, I will present you or give you an overview of the last findings within this anomalies. So if we focused on the interferonopathies, it's a part of monogenic lupus. Monogenic lupus can be driven by anomalies of apoptotic bodies and defect in the clearance of apoptotic bodies. This is another part. It could be also related to anomalies in T and B cells. This is also another part. But I'd like to point out today the anomalies in type 1 interferonopathies. So interferon, as you know, they have been initially identified as a key antiviral cytokine that are critical to fight against viruses. It was identified in the late 50s. And nowadays, the mechanisms are more complicated in some extent, but all of them here in this picture, you can see the different sensing pathway that can detect nucleic acid, either from the cytoplasm, within the endosome, or outside the cells. But all these sensors concur to the production of interferon, type 1 interferon, interferon alpha 2 especially. And there is then a connection to the heterodimeric IFNA receptor that will then signal through JAK-STAT and induce the so-called interferon signature made of interferon-stimulated genes. It's easiest to capture these anomalies, the interferon signature, than the interferon alpha itself, which is at a very low level in the serum of patient. And except if you have a CMOA to analyze this cytokine is very challenging. So this is the reason why we often looked at the interferon signature. So here, this is a picture of your cells that globally are made of sensor that can detect foreign material and DNA, RNA, and provide an interferon expression when this system detects nucleic acids. This interferon will be sensed by the receptors, IFNAR, and then go through JAK-STAT signaling and induce this interferon signature. And we currently use to look at this signature on a routine basis in Lyon. Couple of years after the first description of the interferon, Jean Aicardi and Françoise Gouttière, two neuropediatricians at the Necker Hospital, identified a disease which was recurrent in the same family that looks like a Torch syndrome because of the brain calcification, microcephaly, encephalopathy, with a very early onset. And at the time, they looked at some congenital infection, but it didn't identify any infection by toxoplasma, CMV, mumps, etc., rubella. So it was even recurrent in the same family, so highly arguing for something genetics. And 4 years later, Pierre Lebon identified in the CSF some expression of interferon alpha. So that was used as a biomarker of this disease. But it's only more than 20 years after that the first gene was identified by Yannick Crowe, and this gene is named TREX1. It's this gene associate or explain why we produce too much interferon alpha for these patients. And other colleagues then also identified TREX1 mutation in some patients with childblain lupus, and even in systemic lupus. That was an interesting finding because some Aicardi-Gouttière syndrome patients develop later on lupus phenotype. But it can be also associated to systemic lupus without any neuroinflammatory disease, which was particularly interesting. Now we know that about 7 genes have been reported for Aicardi-Gouttière syndrome. And you see here the broad spectrum of the phenotype of this patient that comes from very severe early in life phenotype with an encephalopathy to later onset spastic paraparesis, for example, some even isolated intracranial calcification, and even in some patients, no symptoms, just a positive interferon signature. And here in this picture, a video, you see a patient who has a Aicardi-Gouttier syndrome. He has no mental delay. He's totally, the intelligence is normal, but there is this paraparesia. His father suffered from the same disease with childblain, and the great father was totally normal phenotypically, but present a positive interferon signature. And it's just a way to say that there is in the same genes the possibility to develop lupus phenotype as well, either childblain, isolated childblain in some families, or systemic lupus. And in a single family, they could have lupus phenotype in one index case, and in the ascendant, you can see a paraparesia, for example. So it's important for clinicians to connect these possibilities that can occur. The gold standard to check for this disease is the interferon signature. You can demonstrate in whole blood quite easily that there is an interferon signature in these patients. That's always increased. Almost always, a few of them can be negative for RNase H2B genotype, but it's quite uncommon. And we have set up this assay in France, and we are running about 2,000 interferon signature a year. And I definitely think it's a very useful marker for routine purpose, not for only for research, as it can detect this interferon even in people with the normal CRP values. So here, this is the main anomalies identified with interferonopathies, so anomalies in the metabolism of DNA, RNA within the cytoplasm. There are also some gain of function mutation of the sensors. And I will give a few words on new finding on JAK-STAT and also on TLR biology. So here it is your cells that can detect DNA, RNA, and as soon as it's detected in the cytoplasm, you'll produce large amount of interferon. TREX1 is actually an enzyme, as the other enzyme listed here. The job of this enzyme is to destroy, to digest, or to metabolism, to take care of this DNA, RNA within the cytoplasm. And initially, we could imagine that the nucleic acid in the cytoplasm essentially comes from the outside, from viruses, outside viruses, infection, viral infection. But actually, within the nucleus, about 6% of the genome is made of human endogenous retroviruses. It's very interesting to point it out because, you know, we have 1% of the genome that encodes for the exome and 6% that encodes for this ERV. And these retroviruses were not thought to play a major role, but actually there is some ERV that can replicate within the cytoplasm. And there is a balance between the enzyme and the retroviruses that make the cells in a tonal situation when if you have no enzyme, you will accumulate the nucleic acid coming from the retroviruses, the endogenous retroviruses. It's a contamination of your self DNA and self RNA in some extent. And here, this is an illustration of a clinical case that developed an Aicardi-Gouttier syndrome, childblain, and neuroinflammatory disease due to some HD1 mutation. The interferon signature was positive. And what was made in this patient, and that was a clinical trial set up by Yannicro, 8 patients with this genotype were treated with the reverse transcriptase inhibitors as exactly the same treatment we use for HIV infection. And what is really fascinating here, it is if you look at the interferon signature before the treatment, the 8 patients were treated over 12 months, and at the stop of the medication, the signature go up here, as you can see. So there is a possibility in a genetic disease to use reverse transcriptase inhibitors to decrease the interferon signature, possibly by targeting these retroviruses. So that's quite fascinating findings that maybe means that in the future, even the non-genetic lupus could be treated by this strategy. So we will run a clinical trial in France to check whether this strategy with abacavir lamivudine can be helpful to decrease the interferon signature of lupus patients, and that could represent an add-on therapy that is not related to immunosuppressant. This is antiviral drugs. So the second families of interferonopathy are the gain of function mutation of sensors. Here, there is no need of excess of nucleic acid within the cells. It's just that the cells sense too much via RIG-I, MDA5, or STING, which is an adaptor molecule in the cGAS pathway. And here you have the phenotype of SAVI patients that present anomalies of the skin with a component of vasculitis, as you can see here. Some of them present also the lupus-like rash in some extent. The thing is that in SAVI patients, as in COPAS patients, there is the lung disease that is prominent, that can even start as the initial symptoms of the disease. So here you have different pictures showing the interstitial pneumonia of SAVI patient. In our hands, we showed that the JAK inhibitors can be helpful, at least for skin lesion, systemic symptoms like fever. Not so clear for the lung disease. There were a slight improvement initially, but looking further, the lung disease progressed, and our patient was then transplanted. And in France, we reported these 3 patients with lung transplantation. And here it's a picture of the explanted lung. And you see the cyst and the anomalies of this terrific disease. The interferon signature drop up at the end after the lung transplantation. To date, after 2.5 years, it's still well, but we initiate the immunosuppressant, conventional immunosuppressant, together with the JAK inhibitors. So a strong immunosuppressive regimen. But with this strategy, the boy is still alive and in good condition, but we may be very cautious about opportunistic infection, including BK virus. As you know, JAK inhibitors can be a situation where you see replication at the high level of BK viruses. At last, but not least, there are also some anomalies in the JAK-STAT signaling. And here I present the SOX1 haploinsufficiency. We have some natural inhibitors of the JAK-STAT signaling. And if there is a defect here, there is an increase of the interferon stimulated genes that can be detrimental for tissue and for the immune system. So here are presented the known genes involved in this and can be associated to interferonopathies. I just highlighted that initially we identified one boy with a SOX1 variant that was predicted pathogenic. We're not seen in any database, but doing the segregation, we found that the father are carrying the same mutation, but they are totally asymptomatic. So at that time, we thought it was not a good option in terms of genetics. But another family came up with another variant in the same gene, with the one developing immune thrombocytopenia and the other lupus phenotype with systemic symptoms and lupus rash, nephritis. When we look at the segregation, we found a psoriasis in the brother, and he was carrying the mutation. The father was carrying without any symptom, but he has a positive interferon signature. And the hunt displayed many diseases that the adult rheumatologist made, including lupus, psoriasis, granuloma, sarcoidosis. So meaning that there is something wrong, but not clearly identified. So knocking at the door of our colleagues, Frédéric Rieuloca in Paris and Stefan Hill in Germany, we identify a couple of additional families with Evans syndrome. And together we found that, yes, SOX1 is our natural JAK inhibitor. There is a variable expressivity. Some patients carry the mutation with no symptoms. And as you may know, SOX1 is the most potent JAK inhibitor we have in our cells. And in mice, the SOX1 knockout is lethal with a systemic inflammation, and heterozygous mice develop also some phenotype looking like lupus. Here, this is an illustration of how we can treat the patients with the JAK inhibitors. In case of psoriasis, it was deeply increased and improved by JAK1/2 inhibitors instead of JAK1/3 inhibitors. That means maybe something. We have just a publication in press on PTPN2 that seems that's another JAK inhibitors. And again, Evans and lupus syndrome has been identified in this population. And I will finish by the TLR-opathies, which is maybe the most recent field of monogenic lupus, with 9 patients identified in 6 families with TLS7 mutation. It's dominant mutation, gain of function. The group of Caroline Vinuesa even produced the knock-in mice with TLS7 knock-in that recapitulate the phenotype, showing that this mutation in TLS7 are causal with an excessive TLS7 signaling. And in the same pathway, UNC93B is another gene that is really mandatory for the TLS7 signaling. And a number of teams have identified also monogenic lupus within this gene that can explain the lupus phenotype with a lot of functional tests. So it seems that TLS7 and its related molecules are really critical for the lupus phenotype. To my opinion, but it's just a conceptual slide, it's possible that systemic lupus is essentially associated to anomalies of the external nucleic acid metabolism anomalies, while the Aicardi-Gouttière syndrome is related to the intracellular anomalies of nucleic acid. And of course, there is an overlap between these two situations, and maybe nucleic acid and its source is important for the phenotype. As a conclusion, I just want to mention that monogenic lupus is a really fascinating field with a new player in the very recent years. I'm sure there is a lot to discover, especially in the field of early onset lupus, familial lupus, syndromic lupus. So think about this, about 10% in our hands of non-selected pediatric lupus are due to single gene mutation. You see the different phenotype associated to different genotype. And knowing this is very important to decide the personalized therapy in these patients that comes from bone marrow transplantation to JAK inhibitors or to B-T cells immunosuppressant. And I'm sure there is still a lot to understand, including somatic mutation in this field. And I would like to thank all the colleagues that worked with me together on this situation, including the families and patients that are really critical, and you for your attention. And I'm happy to take questions, so don't hesitate to write me an email or to contact the Filière FAI²R, which is our host today for this webinar. Thank you.